All right, good evening, everyone. This is our master class for December 2022. We have a special guest, Dr. Elliot Dinetz, and I would just ask everyone to please mute themselves as they enter the room so we don't interfere with the speaker tonight. And Dr. Elliot Dinetz, I'll let him introduce himself and tell you a little bit about what he does. And he's going to be talking to us about peptides and how they can optimize the immune system and performance and weight management. All right, Elliot, take it away.
All right. Thank you for the introduction, Dr. Salibi. My name is Elliot Dinetz, and I am, I guess you would say I'm a former primary care physician, board certified family physician and integrative medicine doctor with fellowship training in both metabolic and functional medicine, and some training in clinical genomics thereafter. So really a precision medicine practice that I have here in Miami, Florida. And I've been using peptides for a couple of years now. It started as an elementary experience with the GHRP and such analogs for hormone optimization. And then I learned a lot more of what was out there. And I became pretty fascinated with it quickly based on the results that we were getting. So I'm going to be presenting on some of those today. As the topic is peptides and optimizing health and performance, reversing immune dysfunction. So many of us already know the importance of that immunity when we age, and we think of inflammaging, the condition of inflammation that produces an aging phenotype in our bodies. That's what we'll kind of discuss, and I kind of wanted to make it fun while also very educational from a root cause perspective and a biochemical perspective, because I believe this is the future of medicine. So if there are no questions, I will go ahead and start. I have no relevant financial relationships with any companies to disclose. And I start with a slide that's pretty obvious for those who might still be in conventional practice, that, nearly all the healthcare costs are attributable to health, unhealthy people. In other words, chronic disease. A continual increase since the 1950s, which we remember that diet, that lifestyle, that post-war mentality that was then, until we found out, well, shoot, our life expectancy was growing initially, and now it's declining. So if you haven't looked at that recently, it's very intriguing to see we were once in the 80s, and now we are not. We're in the 70s, as far as late 70s for life expectancy. And 7 out of 10 people, that's not a joke, that's new data, have chronic disease. But I'll put it to you guys in a better context. 12% of Americans are healthy. And we'll talk just about what that means in the context of obesity and the immune system. So when I talk about longevity and health balance, right, there's so many factors that contributed to, so I like to keep things simple and in threes. Lifestyle, of course, nutrition, we think of being a key component. Again, that was the reason in that post-war era, in the 50s and after, it was steak and eggs and milkshakes and, not very much of the produce there, indicating a successful economy. If you look around the world, what do people end up eating when they get rich? And that should surprise you. That is known as an inflammatory diet, okay, or not the anti-inflammatory or Mediterranean type diet. So we have that. We have the exercise, which is the old term for it, but really functional capacity. We can now test that today, and I encourage many of you guys to do that if you're into wellness and longevity. We can look at VO2 maxes and see what our oxygen consumption is per minute, and what we're capable of doing at extended periods of exercise. And that's where we get the recommendations that we have today, is really knowing that longevity is associated with at least 150 minutes a week, but really optimal health is an hour a day or so of physical mobility, which I tell people is not walking, right? They always tell us that, but that's not the case. So lifestyle is always the key crux there. right, between those two components, then we have, of course, hormones. And as someone who practices functional endocrinology and age management medicine, as we age, the hormones decline, right? When we decline those things, we lose our mesenchymal stem cell simulation, and therefore organ tissue decline, and so on. We lose our protective and anti-inflammatory edge. Right? That's what we know. We know from autoimmune studies, testosterone is protective in that regard. So we have hormones, and then, of course, immune function. With age, and we accumulate inflammation, as we talked about, it has an impact on our immune system. And virtually all studies and the testing that I use in my practice, epigenetics or epigenetic true age testing, will look at what someone's chronological, you'll write down your chronological age and we'll see what your true biological age is. And if that's basically younger or older than your current chronological age, can tell us a lot of info. And I've done separate presentations on that, which have been pretty helpful for audiences to see that there are so many environmental components that are attributable. So these are the three components that I like to introduce, at least, how peptides can influence that, because they can influence our hormone system from growth hormone to testosterone production. They can also have an impact on our exercise tolerance by doing so. And also what I find is on a social level, peptides can make people more motivated. They know they're getting the right juice in their bodies. They've made a commitment and they'll do more. And it works sort of vice versa in that regard. But into immune function and efficacy, that's something that I find is not as discussed. And since it has such a tremendous impact on longevity, that's what we'll be talking about a little bit in here. So what do we know about the current use of peptide therapy? I looked through the data and saw that hormonal boosting versus replacement, so a more physiological approach is now available. Plenty of data on that and how it works. And it's safe because what are peptides? Peptides are amino acid chains, right? Bigger than a single amino acid, not quite as big as a protein, and their configuration can hit on our different cell surface receptors. Unlike steroids, which are fat soluble and have to enter through the outer cell membrane and the inner membrane of the nucleus and affect gene mRNA transcription in proteins, those take a while to have an effect, and these can work a lot quicker, which is an interesting approach there. So while it can increase earlier on our signaling, if you will, it still has to go through that same process, but again, a physiological one. So it also controls, we have a plethora of data on controlling metabolism and appetite. Many of you have seen the New England Journal of Medicine article on semaglutide or Ozempic. That GLP-1 agonist is strongly impacted, has strongly impacted obesity, and I've seen it in clinical practice. People have achieved metabolic goals that they haven't had in 40 plus years. So we're in a real interesting era thanks to these peptide therapies. And lastly, immune modulation. And that's what we're going to discuss a little more today.
Are these people at the meeting?
We're all good? Okay. So I wanted to start with a case. All right. So we can kind of get kind of into it and how metabolic health relates to immunity, since that's going to be the crux about, and obesity. So we had a 68-year-old male who struggled with obesity and have a BMI of 30, and it alternates to 30 to 35. He knew his risk for metabolic syndrome, right, has been discussed with him, prediabetes, aging, and of course, infections after the past couple of years that we've had, right? We know obese people were at higher predispositions for COVID and mortality, basically having a more rough time. The patient denied any other past medical history other than borderline hypertension related to his weight, and that was really it. He wanted to just get better. Well, here we have plenty of evidence that shows the pathophysiology and epidemiology of a double pandemic, they call it. This was published earlier this year. Pet obesity is not only related to an increase in COVID, but it's brought to the light that it increases lower and upper respiratory infections. It's seen higher incidences of dermatological infections. And we know this from our residency training, right? Remember those people that kept coming in with cellulitis that were morbidly obese, keeping us in the ER overnight, that were waking us up at least if we were on night shift. And I remember that pretty vividly. And then also UTIs were associated with an increased risk of that. And we're kind of now seeing this coming to light. We know that it increases macrophage infiltration and lymphocytes, focusing on, in those tissues. And depending where, if you have visceral fat, right, which we know is more, we've always learned it's more associated with morbidity, mortality. And that's because it's secreting those inflammatory cytokines by that immune inflammation next to your key organs. So we looked at this guy and we said, okay, let's take a look. He had normal transaminases. He had an elevated fasting blood sugar above 90. In my case, if it's above 90, it's elevated. It's really high if it's above 100. I don't care about the conventional guidelines anymore. Morbidity and mortality, especially when it comes to cardiovascular disease, if it's above 85, you're at risk. His A1C is pre-diabetic. He had an HSCRP of 2, some inflammation that's subtle, and triglycerides 155 and an HDL of 40 with a waist size of 34 and pre-hypertensive. You might be wondering why I'm putting these labs in there, but you probably guessed that's metabolic syndrome. He's teetering on that, right? He meets every category except the waist and borderline HDL, but I think the CRP right here should definitely be part of that criteria because that's known inflammation that we see, especially in this case. And on the right, we have a wonderful diagram of what metabolic syndrome does do to the immune system. So the metabolic tissue, okay, in that adiposity leads to basically a loss of lymphoid tissue integrity, right? They're getting infiltrated, right? That can lead to chronic disease. But going around the cycle, it alters the distribution and subsets of your white blood cells, okay? And there's your impaired immunity. Elevated blood glucose, I think of snow. Think of snow covering your car outside. When you go to look for your car and you're like, which one is it? Where did I park? It's because it's covered in a coat of it. That I think of that as sugar, okay, and how glucose can really impair our immune cell receptor function. And then, of course, pro-inflammatory phenotypes that we talked about endangering the organ tissue and on a larger scale us. So for this individual, we knew he was at risk, even though his LFTs weren't elevated. Liver ultrasound would have likely shown by now the starts of a non-alcoholic fatty liver disease or NASH. And why? Because I see that with everybody who's got elevated blood glucose and metabolic syndrome, but also because semaglutide really, we used it because it's a safe and effective way of hitting on, I call it 3 main things. It lowers improves hepatic health by increasing decreasing gluconeogenesis in the liver and encouraging liver detoxification thereby. Okay, and also that is indirectly because we're slowing the absorption of glucose by the GLP-1s, right? If we remember our pharmacology, that's how this drug works. So it's a physiological way of telling the body to stop absorbing sugar, to increase satiety or hunger, to stop, and to effectively stop the liver from continuously processing glucose. What that does is then you have normal lipids. So lipids can come in and be able to have their ability to be processed. So if you don't have that working, you have all of these problems mounting, which is essentially metabolic syndrome and then disease. Okay, we know how it works on the pancreas, of course. More insulin is synthesized, okay, and blood glucose as a result lowers. The gastric emptying we discussed, but also on the brain and heart, I wanted to mention these additional 2 things. A lot of physicians aren't aware of this, that it can actually increase memory, neurological impairment will go down, synaptic transmission will go up. And then on the heart, if you want a pathophys lesson, a great drug to learn that from is this one because it's cardioprotective. Every cardiologist we work with, every functional and integrative cardiologist, that is that we know it has anti-inflammatory action, so that's good. You're decreasing the adiposity. Obviously, that's good because of proximity of visceral fat and inflammation, but it's lowering blood lipids and helping atrial natriuretic peptide. Okay, so we've got it working really everywhere. And I can't tell you how successful this has been in my practice, but now we know even more, it has an effect on the immune system. So we're actually preventing them from being sick with their age. So the results in that patient after 3 months of sequentially increasing his semaglutide dose to tolerance, lost 25 pounds, fasting glucose got down to below 85, cravings for foods and alcohol diminished, and his immune function was optimized. He hadn't been sick, and we know that's really good. And we can even go further and test that if you wanted to on inflammatory markers. So we see how obesity and weight management are critical to immune health. And now we're actually going to go deeper into peptides that I use particularly for immune modulation in sick patients, kind of like what Dr. Salibi was talking about earlier on the patient that we had tremendous success with. So I love this diagram. I hope it's not too busy for people if it might be a review. But our bone marrow right here, that's the good stuff, right? That's where our white blood cells, red blood cells, and platelets are made. And these white blood cells will travel to the thymus, which naturally involutes over time. By 80, we practically don't have a functioning one. And after middle age, it's not functioning nearly as much. Okay, that's critically important because we learned in med school, I don't think I've ever heard it mentioned again, right? That it's critical for, positive selection, so there's no autoimmunity. Remember that key importance when, you have a refractory autoimmune case. That's an important site for that because that's how we recognize self and we put out, the right T cells that do their job. Now, the thymus also separates them to CD4, CD8 cells, which CD4 predominantly is after fungal infections, for example, so mycotoxin illness.
Dr. Laura, join the meeting.
And CD8 is more viral. We know the CD4, CD8 ratio is very low in particularly immune suppressed patients, HIV patients, etc. And it's critical to know that from that, as a result of that ratio, you really don't have your T regulatory cells as well as your Th1 and Th2, T cells. So, your Th1s being the pro-inflammatory as well as Th2, but more towards a histaminic response that you see in allergies, asthma, eczema, right? The more dermatological results. And you can kind of see where somebody is dominant based on your T cells or clinically. And you also make natural killer cells from this. So it's critical not just to boost the immune system, no, to modulate it. So you have your anti, as I said, the Tregs, and your pro, so that you can actually help fight. And that's critically important in patients with Lyme particularly, which, or chronic viral infections that drop our white count. So it's been long known that peptides, particularly these thymus ones, which include thymosin alpha-1, thymosin beta-4, that can have autocrine as well as paracrine functions. They work on the tissue to rejuvenate, as well as do their jobs on the immune system. All right, and that's what I think is so important. Move this over. Better. So another diagram of a thymus gland for people, and when it's young, you see you have a lot of tissue there, and then as it's aged, you kind of have more of that fibrous cap and perivascular space. So involuted, but you can actually rejuvenate it, which is impressive. And it also lowers NF-kappa beta. It's anti-inflammatory. So important to know when you're dealing with patients. So let's talk about clinically. What have these peptides done? Some of you might not know this, but I looked through the data about its efficacy in COVID. This is what got it into notoriety, okay, particularly targeted by certain organizations because of its tremendous efficacy. One study, which was pretty large, revealed a decreased 28-day mortality, and I don't need to say anything else other than that hazard ratio. That's no joke. So that's one study, right? But we know exactly how it works. So that's the way I evaluate a product. First off, safety. The known safety has been there for peptides, again, because they're pissed out of the body within minutes because of the composition. They're simply peptides, water-soluble peptides. So they're known to be safe. In any literature search you do, we know the mechanism of action on the most heralded source of longevity, the thymus gland, and we've seen it work. So then another study that followed that was interesting. They said it didn't really have that much success, and it was actually, if you actually read it, it showed that another study showed for males the hazard ratio was 0.6. So again, we're talking like a 40% decrease in mortality. I mean, and then the other one, which is over 80%. This is, very important. But apparently in that second study, there were no other subgroups that benefited. The only issue is those arms weren't statistically significant. So what other controversial studies will come up when you do a search of COVID? Misleading headlines, if you read them, because I'm very interested in this. So a couple from China, in particular one that was a retrospective. So there's two biases, selection and confound bias in the retrospective studies. So you always take that with a grain of salt. And they saw that if it was given only to more severe cases because they were in desperation to help these people, in addition to IVIG and steroids. Steroids are going to suppress the immune system, right? And they were like, yeah, there was no real improvement in CD4 to CD8. What was interesting is even when they gave it to those people in survival, I saw, or to those people who were in dire situation, I didn't see any discussion or mention in the papers about their survival. I would have loved to see that. But again, confounding variables that I mentioned and bias need not look further than the fact that they gave it to more severe cases who might not have had time to live in order to increase their CD4, CD8. They're already on steroids. They had more steroids than the other group, and other factors that can do that. Lastly, I think they were given it once or twice a week as opposed to which most physicians are using it subcutaneous daily. So interesting, right? We need more. I would love to see more and more, but it makes sense to us. So this is a case report we had regarding the use of these thymus and peptides. A 28-year-old female with a long-standing history of chronic fatigue syndrome diagnosed by her primary. She was offered really no treatment. There was no suggested etiology, but they did do the testing and saw chronic viral infections and didn't have any fever, joint pains, and screening for Lyme and SIRS were both negative. Okay, she came into us, unfortunately, already gluten, dairy-free, elimination, diet focused, and she just couldn't exercise. That was the only thing because she was so fatigued. She would need to be in bed for 10 hours in order to get 9 full hours, and otherwise she couldn't function. She'd been living with it, and she used a lot of wearables, the Apple Watch and heart rate variability and all these things to kind of monitor her sleep and recovery so she can do better. And I like patients like this, and we should encourage ours to do the same and provide us with at least some sort of feedback while they're not in with us. So sure enough, I reviewed her labs, and she had both the viral and early nuclear antigens, were elevated, antibodies that is, very elevated, more than detectable on Quest is more than 600. So she was right there, less than 36 is normal, as well as CMV. So we took a look at our own labs, and you can see her white blood cell count was very low. So she's not really mounting any sort of a response there. And we know chronic viral infections can do that. A little B12 or folate deficiency based on her MCV. But, conventionally, or even other functional physicians might not, they could overlook it because of her homocysteine, CRP, oxidized LDL were all normal. So there's no significant inflammation, although labs, don't read, a patient doesn't read the textbook. neither does the disease. We have to interpret that based on their clinical presentation. Labs are variable. You can get it at the wrong time. It's misused. And sometimes they just might not be positive. That's why being a clinician is so important. So I took a look at her wearables to see if they could help us. And here's what we saw. Saw some really rough recoveries as she gets towards the end of the work week. Okay, and then come Sunday, probably the stress of work, from what she tells me, was affecting her as well. And on the second diagram here where my cursor is, you can see that she's just not getting that essentially recovery, which was looking at heart rate variability, heart rate, and respiratory rate, just those things. And it correlates with how she feels during the week. She's, she can't mount enough of a stress response, probably, and recover in time with sleep because of the chronic inflammatory state that she's in. I hope that makes sense to everybody. Chronic viral infections, an imbalanced immune system, and poor recovery time. Okay, and we know there's a lot of data on heart rate variability, or HRV. So she makes it back up over the weekend, and then it comes back down. So right away after starting thymosin alpha-1, we start 20 units and then go up to about 40, 50, which is about a gram and a half where the literature resides. You can see here, she started on the 19th. So she was already going to recover over the weekend, but look at that. A typical weekend for her was recovery, and then during the week, she starts to crash, but she made it all the way past Wednesday, doing much better. Is she perfect? No, she did come back down again towards the end of the week. Again, it's one aspect, right? If she's not going to get enough sleep, she's not going to be able to recover, and that's where she was stuck in her busy job, and still is struggling with. And if you look here to the right, look at her heart rate variability recovery. This is when she administered it, and it went up here. And, if she didn't go to work, she would probably be a lot higher. And we talked about this. And she wanted me to let everyone know that despite that, her clinical improvement was significantly better, 50 to 60% within 4 weeks of doing this. So that's really important. That shows us that we've modulated the immune system, not just given it to her. And it's that those T regulatory cells can calm the inflammation and dampen that fire that's on, and put that fire out. Therefore, she can actually have a chance at higher recovery. If she didn't, remember we talked about 9+ hours, she would not feel any recovery, but she does. She feels like if she doesn't sleep her 9, if it's 6 in her busy week, she can still function, whereas before it was devastating. So interesting case, and I don't think she's done with that. I think that we continue that a little longer and further encourage antiviral therapies with high-dose IV ascorbic acid, continuing her on LDN, which she's been on now for just about 3 to 6 months, and hoping that can turn the corner on this individual as well. And we have other options to add. And I wanted to bring that all into a third case of a 15-year-old male who's diagnosed with Crohn's, here where I live in Miami. He was having 4 to 8 bloody bowel movements per day, was started on rectal suppositories after failing budesonide trial, and the discussion came up whether to place him on immune suppression. That is not a discussion any of us want to have. Otherwise, we wouldn't be in this group. But that I speak to don't either. And they want answers. They want to help them. They just don't have the advanced training we do. He was pulled out of school subsequently with a 4.0 average and everything, and the most supportive family I think I've ever seen. So they wanted to see us, see if there was a better approach. So in-depth questioning found some interesting stuff, some migratory joint pains. And if you don't know by now, that is a pathognomonic sign practically for Lyme disease. Did he travel to the Northeast? No, he's Ecuadorian. They travel to Ecuador quite often, but not to any Lyme endemic areas. And that should also be known, as Dr. Salibi himself here is a Lyme literate physician and knows it does not have to be someone who resides there Lyme is all over the place. It's now in China and other areas, and it's sexually transmitted, and there are co-infections. So it's something to be cognizant of. But he had rectal pain, brain fog, fatigue, you name it. So that resonated with me, and more testing, was paying attention to the clinical picture. His basic labs were completely unremarkable. So we decided, okay, he was screened and we tested him for Lyme, and sure enough, he had Borrelia burgdorferi and several Borrelia organisms and other viral co-infections as well. He further had a low CD4 to CD8 count and a CD57 that was low, which is indicative of natural killer cell function. So this guy's, he couldn't fight anything, and we know Lyme can do. Okay, so the initial approach, before we even got these labs back, were to start him on LDN. We started IV antioxidants and therapies. We, changed his nutrition to focus on his microbiome and gut health, all with that significant impact after several weeks. So a more precision approach, we referred back to the labs. We noticed his immune cells probably are just not going to be able to do this, and with just modulating it with LDN or even treating the virus itself. So we needed to get that rejuvenated, right? That thymus gland functioning better, or doing its function. So to rebuild his immune soldiers, we started two things called cemento and banderol. If you're familiar with cat's claw and other such ingredients, 1 ml each was the target goal. We went up to drop by drop to address the Borrelia. And there's a decent amount of evidence out there that it works very well, plus a plethora of clinical data as well, where the anecdotal evidence is pretty clear. So with just doing this for about 6 weeks plus, it reduced his bowel movements. Just about under 2 months. He had only 2 per day, no more blood, no more pain, no more migratory joint pains. So you're like, oh my God, this is amazing. But he was still struggling with persistent brain fog and fatigue. He couldn't go back to school. They were really holding on to hope, what else we could do. So we can't rest there. We're thinking, okay, we address the Lyme that we intended to treat along with the LDN, right? And IVs, but again, his immune system needs rejuvenating. So we finally had in our clinic Thymus and Alpha 1, and we started that again at 20 units and then increased to 0.4 milligrams or 40 units, and titrated up to 1 milligram 5 out of 7 days a week. So we gave him a weekend break. He is a kid. Why did we use cemento and banderol? I think people would all agree a 15-year-old should not be on doxycycline or any other toxic antibiotics that can disrupt his gut further, which we have a lot of data on how doxy does that. Way beyond just the teeth staining and conventional reasons. The microbiome is ravaged by it, and I thought this would be an excellent first choice, and it turned out to be good. The Thymus and Alpha, within 2 weeks, and 4 weeks later, you started seeing a huge change and then complete resolution of symptoms, which is remarkable. 2 weeks after that, he's back in school. Now we're around 3 months later. He remains in clinical remission. So this was the first case in the literature that we've seen doing a lit review of a pediatric Crohn's patient who was successfully diagnosed and treated and put into remission for Crohn's due to Lyme disease. So we are publishing on that process. And I wanted to kind of conclude with everybody the conclusion and key points. Without a structured functioning immune system, see how I was trying to build my treatment approach, you might not have optimal results. Okay, you might not have optimal results either without peptide therapy and weight. If someone's metabolism is all out of whack, where you can actually rejuvenate that from the gut enteroendocrine perspective with GLP-1 agonists. And same thing. And you can really, at the end of the day, both things are helping the same cause, the immune system. The immune function, I want people to understand, declines with age. There are things like obesity, vitamin D, and environmental toxins as well as infectious diseases, which contribute to that. The earlier publication that I showed about obesity mentions it's low vitamin D. That's part of that reason, because without vitamin D, you have Th17 overexpressed, which is pro-autoimmune. It's also pro-inflammatory, and that's another key component. And by being able to appropriately test for this and effectively modulate the immune systems, many conditions can be effectively treated. We know today thymosin alpha-1 is a bit more difficult to get, but thymulin, I'm starting to use as another thymosin peptide, Thymus peptide, and there's thymosin beta-4, and hopefully next time I'll have more evidence and clinical results on cases using those, so that we can move forward in the right direction and help our patients at a root cause, from a root cause perspective. Thank you guys very much, and I'd be happy to answer any questions or get tomatoes, whatever you guys wanted to contribute.
Hey, Elliot, that was a fantastic presentation. Thank you so very much.